So thank you. My talk is on SCAD. How do I manage in the next 10, how do I image and manage in the next 10 minutes? Um, SCAD, what is it? Well, we all know it's a spontaneous dissection of the coronary arterial wall as a result either of an intimal tear or spontaneous intramural hemorrhage. And that causes a propagating intramural hematoma, which compresses the true lumen and causes myocardial ischemia and infarction. And that's how these patients present. So how do we image patients with SCAD? Well, we have angiography, which is the main mode of imaging. We can use intravascular ultrasound with either OCT or IVUS. And of course, there are non-invasive imaging modalities, which we won't discuss in this talk. SCAD angiography is the primary diagnostic imaging modality to diagnose SCAD, but it is a matter of pattern recognition. And Jacqueline So from Vancouver has done a lot of work on this, and they've described a couple of patterns of SCAD, which is very useful for us to understand and diagnose these patients. Type 1 is the typical SCAD that is very easy to recognize due to an intimal tear with propagation and dye going into the false lumen, and we see the typical tram tracks or contrast staining of the wall, easy to diagnose. The next type, type 2, is primarily related to an expanding intramural hematoma, which compresses the lumen, and you get diffuse compressed lumen, which in type 2 is more than 20 millimeters and is quite smooth and diffused. Type 3 is very similar, except the compression is over a much smaller length, typically less than 20 millimeters. And it could be either a focal or a diffuse narrowing, often quite difficult to differentiate from atherosclerosis. And finally, type 4, where the intramural hematoma completely compresses the lumen and you get an occlusion. This is a representative case of a 40-year-old woman that came in with an ACS. Straight up in the mid-LAD, you see what looks like a severe type a type 3 stenosis. But if you look closer, and it's very important with SCAD, with angiography, to look carefully at all the vessels. And you can see, in fact, the proximal LAD is quite attenuated, and distal to this type 3 appearance, there's actually tram tracks in the distal LAD and another focal stenosis. And also look at the diagonal. The diagonal also has dissection type 1 SCAD. So the dissection started off quite proximally and dissected down both arteries. Same patient, distal LAD, both the PDA and all of the posterolaterals have typical type 1 SCAD. And in fact, this posterolateral probably is occluded, a type 4 type picture. This patient came back 3 years later with another event, and here a typical type 2 SCAD affecting the obtuse marginal. So SCAD angiography, primary diagnostic imaging modality, most cases can be diagnosed with angiography alone. But the incidence is quite variable, suggesting, in fact, that the true incidence of SCAD is probably underreported with angiography. So it has its limitations. We know it's a 2D luminogram, so it doesn't image the vessel wall and can miss type 2A and especially type 3 SCAD. An unfamiliarity with SCAD appearances is especially true for type 2 and type 3 variants, and probably is another reason for under-reporting the true incidence of SCAD. Also remember, even with diagnostic angiography in patients with SCAD, there's a higher risk of superadded iatrogenic dissection compared to patients without SCAD, varying between 2 to 3%, so not insignificant. When you do angiography in a patient with a diagnosis of SCAD, importantly have a high clinical index of suspicion. Be familiar with SCAD appearances and angiography, this pattern recognition, which is very important. Minimize injections. If you diagnose it with one injection, don't keep on injecting the same coronary. There's a risk of extending it. Be careful if you're using auto-injectors. Some people advocate femoral access if you have a high index of suspicion in SCAD. Avoid aggressive catheters such as AL catheters, and of course develop experience with intravascular imaging because you are going to need it at some stage. What are the features that predispose to a high clinical index of suspicion? Well, young females in their 50s or younger with ACS, no cardiovascular risk factors, little evidence of typical atherosclerotic disease in their coronaries, tortuous coronary arteries, and of course predisposing events that would suggest this could be SCAD. Intracoronary imaging with SCAD, when will I use it? Well, when the diagnosis is in doubt with angiography, and it is the gold standard, and in all cases will give you a definitive diagnosis. The other place I would use intracoronary imaging is when I have to do PCI for SCAD cases. Here, I think it's very useful and in fact important. What features of intracoronary imaging do we get in SCAD? Well, all the features, particularly with OCT, the intimal medial membrane, intramural hematoma, double lumen with true and false lumens, and you can in fact see the tear, which could either be the entry or the exit. Here's some representative OCT pictures. Here you can see a intimal tear, the typical intramural hematoma, a bit of contrast is leaked in here. Here, a nice picture of the intimal medial membrane with the intramural hematoma. Here, the false lumen is compressing the true lumen. And even with stenting, particularly with OCT, you can see the appearances really very nicely. IVUS or OCT in SCAD. Well, it's horses for courses, really. OCT will really give you the best definition, best resolution. It will delineate all the features of SCAD, provides excellent guidance for PCI, but there are limitations. For example, if you have SCAD related to the aorto-osteal junction, perhaps you'd want to use IVUS. If you have a very tight catheter-hugging luminal compression from the hematoma, you might want to use IVUS. Advantages and disadvantages of intravascular imaging. Well, the bottom line is if you have to use intravascular imaging in SCAD, you have to use it. So you have to accept the disadvantages. What about the safety of intravascular imaging in SCAD? Now, mostly the data is from OCT, and the largest series is from Jackson. 63 patients, an 8% rate of complication, mostly with extension of the false lumen. And 3 of those 63 patients required intervention with PCI. So it's not without risk. So don't use it lightly. Use it only if you have to. Here's a representative case really that demonstrates my use of intravascular imaging in these patients. A 46-year-old female, overweight smoker, went fishing the previous day, bit of exertion with pulling the fish in, got some chest pain. Following morning presents with an anterior STEMI, ongoing ischemia in the cardiac cath lab. This is the caudal views. You can see the LAD territory is a bit empty. These are the cranial views, which really tell the story. Here's an attenuated proximal LAD and a cutoff. This, to my eye, was type 4 SCAD, although one could argue maybe it could be an embolus as well. Needed to be treated, so we wired it, and you can see now the appearances more typical of SCAD. This is occlusive, so we get a gentle pour with a long 20 millimeter 2-O balloon, which is in fact pretty safe, enough really for us to do an OCT. And this is our OCT. Just to run it through in the interest of time, you can see often you see an adventitia, which is a little bit unusual, just distal to the dissection. And here, typical features of SCAD. Importantly, in the more proximal segment, what I want to show you is that this, in fact, extends into the left main. And it's here really important to get very good, clear imaging. And you can see an exit or an entry site here very clearly see. This is some stills just demonstrating the same features. And of course, how are we going to size it? Sizing is very important. So in general, what I tend to do is look at the largest lumen. You can't do media to media here. Look at the largest lumen and probably upsize by about 0.25 and go very gently initially, because you can post-dilate if you want to later. Here, there were 3 intimal tears here. Here are 2 of them, distal and proximal. So we decided to do with a proximal 3-0 stent, nominal inflation, followed by a distal stent 2.5, nominal inflation, no aggressive post-dilatation, with a very nice final angiographic result post-GTN. This is the final OCT, and as you can see, no distal stent issues. You can see the hematoma tacked up by the stent, beautiful imaging with OCT. This is the advantage really with OCT here. And then looking at the entry sites being blocked off, and more importantly, our left main, no extension of the hematoma into the left main, which is obviously very important. So utility of OCT in this case, it was really helpful to confirm the diagnosis, the extent of dissection, particularly in the left main bifurcation area. It had identified the sites of intima media tears. We had 3, so we didn't need to go with a cutting balloon because just with stenting would decompress the hematoma. It importantly confirms the wire position in the true lumen. It helped our PCI strategy with stent sizing, positioning to minimize hematoma propagation, and importantly confirm satisfactory final result. We now have a lot of algorithms for imaging in the diagnosis of SCAD. In the interest of time, I won't go into it. A number from Jacqueline So's group. And we also have some algorithms to help you with PCI in the context of SCAD, and that's a talk in itself. Remember, though, importantly, most cases of SCAD can be treated conservatively. So if the patient doesn't have ischemia and they've settled down, just don't touch it. Medical therapy works. Most patients will heal. We don't know the exact incidence because we try not to restudy them unless there's doubt in the initial diagnosis. And this is that patient of ours who turned up 2 years later. This was her OM type 2 SCAD, and this was 2 years later. It's as if nothing ever happened. Thank you.